So thanks everyone for being here, and good morning from Sydney. I'm always slightly scared presenting to this group because in some ways it feels wrong to tell you stuff about, I guess, which might affect your lived experience, and I always worry about saying something that's not right, but we'll do our best today and see how we go. So those of you who have been to big dementia conferences would have seen this graph being shown, which is how we're starting to think about the continuum of Alzheimer's disease. So with, people who are cognitively normal showing changes in A-beta pathology, which is tau, way before the symptoms of mild cognitive impairment and dementia come about. And as we've started to, I guess, as epidemiologists, as scientists, think about dementia having a much longer kind of lead time, there's been a lot of work in prevention first, where we used to just do work on cure and delay and work on care. So if we look at the priorities for, these are international priorities published in the Lancet Neurology, priorities for where research money is going. A lot of money is happening in prevention, that's the blue here, in diagnosis, which is also helps with prevention, biomarker development, in some drug research, and understanding of normal pathology, which is this kind of pinky buying, and not that much work, I guess, on treatments or even care. And I think that reflects, I guess, the call that DAI and us have had about, focusing on care as well as prevention research. And I think that this focus, I guess, on this very biomedical model of dementia, which is true and correct, I'm not saying that's not right, kind of has us thinking that dementia is a disease of the mind, of the brain, which it is, but that it's a disease of the mind, and then when you lose your brain, which you literally do in dementia, that you lose your mind and then you're not a person anymore. And this is the first image in Google when you Google image dementia. And so treatments then are about treating the brain and kind of, putting back things in the brain or putting back things in the mind. So it's a very biomedical model that most of our dementia research kind of uses.
Can't hear anything.
And I want to contrast this, I guess, to some thoughts of dementia also as a social disease. That a lot of the experiences of people with dementia having a disease, but to do with...
Sorry to interrupt for 1 second, Lee-Fay. There are some people here who haven't muted their audio, and I haven't been able to. So if anyone's joined us, please just check you've got your audios muted. Thank you.
Yeah, so the thought of, I guess, dementia, the experience of having dementia as very much being about how society and people around you treat you as much as a disease of your brain. And as I was thinking about this, I guess I was thinking about pictures of dementia that I've seen recently, like this one from the conference in Chicago, where Kate was given her Richard Taylor Award, and how that's such a different social experience to the images that I typically of dementia in the media. Or this one of I guess, a leader for us in some ways, Christine Bryden, or this one of Trevor Crosby. Though if you don't know Trevor, you don't know which person he is, because you can't really see which person has dementia. And this beautiful one of John Glennis, which is quite a different depiction, I guess, of dementia that we kind of stereotypically see in the media. And thinking about dementia as a social disease as much as a biomedical disease. So I guess I blame Kate for a lot of the work that I do these days. And at a ministerial conference quite a few years ago now, Kate said that there were 3 topics of significant importance to people with dementia. And the third one was about research that focuses on pre- and post-diagnostic care and rehabilitation. I think Kate's been saying this for many years now. And some people are starting to listen. For example, in the WHO Global Action Plan, it does have an action point on promoting community-based rehabilitation. So in this continuum of Alzheimer's disease, and you could take this continuum to reflect other types of dementia too, even though we might not have as good information about it, I'm kind of putting rehabilitation here, kind of in the cure, between cure, delay, and care, and kind of saying that based on all the arguments that Kate and other people with dementia and other people are making, that we should be really doing much more research in this area, not just focusing on prevention and not just on care, which is slightly different in my mind anyway. So what is rehabilitation? I think these definitions are really important. So rehabilitation, as defined WHO, is a set of measures that assist individuals who experience or are likely to experience disability to achieve and maintain optimum functioning in interaction with their environments. So it's for anyone who has disabilities, which people with dementia have, or are likely to experience them, which they might do if they don't have them now, to achieve and maintain optimum functioning. And it's functioning in any area of life in interaction with the environment. So this includes social functioning as well as physical functioning, memory, psychological functioning. And WHO says that the aims of rehabilitation are to prevent the loss of function, to slow the rate of function, to improve or restore function, or compensate for lost function, and maintain current function. So I think that some people think in their heads that when you rehabilitate someone, that you get them back to where they were before. It's not quite right. It's about slowing loss of function and also compensating for things that are wrong. So for example, use of technology counts as rehabilitation using this definition. And also helping someone to just keep going the way they are, not getting worse, counts as rehabilitation. So I'm going to talk a little bit later on, I guess, about expectations of rehabilitation, how, you know, some clinicians have this idea that you have to get people better and their job's to get people better. And if we work with people with dementia and they don't get a lot better, that we somehow failed. And perhaps we need to adjust our attitudes or our expectations about what rehabilitation can achieve as well. And I guess I love this idea by Linda Clare, who talks about rehabilitation for people with dementia as being a practical framework of positive support. So very much in the idea that rehabilitation for people with dementia is about addressing the social disease, not just the biomedical disease. So what evidence is there? I know that many GPs anyway think that there's no point in diagnosing dementia early. And a team of doctors I was talking to, I don't know, not 2 weeks ago, said that their team didn't believe in, geriatricians didn't believe in diagnosing dementia early unless there was a reason to, because there was nothing you could do. And they said, well, it's just a label that doesn't help anyone. So there are some interventions which seem to improve function in people with dementia. I guess we have the strongest evidence for physical exercise. To orientate you to how to read these graphs, because they're quite tricky. On the left, it lists all of the studies that have been reviewed systematically in a study. And on the right, each bar that you can see is the range of results that they got for that study. What the statistician does is that they average each line out and weigh it by how many people were in the study, which it shows as well, and it gives you the average kind of effect across all the studies reviewed. So in this study, in this review, there were 691 people included in all the studies here, which is about physical exercise for cognition and dementia. And it shows basically that if you exercise, you improve your cognition if you have dementia. this echoes very strongly lots of data in people with MCI and people with, who are aging without dementia, which also shows that if we exercise, you improve your cognition. I mean, this evidence is enough that some of the dementia clinicians I work with are prescribing exercise, like they write it on a pad. You know, so after the diagnosis in the Prince of Wales Memory Clinic, Henry Budati would say you should exercise. He puts it down on his pad or his letter of prescription. So exercise, we don't know exactly how much, we don't know what type, but the recommendations are 3 times a week. Cardiovascular and resistance training seems to both be beneficial. There is also evidence, less studies, but evidence as well, that if you exercise, it improves your activities of daily living or self-care functions in dementia. This, again, you read the graph the same way, and it shows the line here favors intervention, showing a small improvement in this relatively small number of studies, but less evidence that if you exercise, it improves your quality of life in dementia. This study, this review looks at combining exercise and cognitive activity to improve cognition in people with MCI or dementia. So combine MCI dementia if we think of it as a continuum. And it's showing that if you exercise and you do cognitive activity, most of these studies, there was some kind of computerized brain training, that that combination also improves cognition. Though we don't know for sure whether whether if you do cognitive training on top of exercise, whether it gives you more benefit or not. So I guess moving then to brain training, we see lots of money poured into brain training. This picture is from a study done at Sydney University in Michael Venezuela's lab. And we know in studies of healthy older people, so people without dementia, that, and there's lots and lots of studies you can see in this long list, that overall brain training improves cognition. But that evidence isn't as clear in people with dementia. So this review suggests that if you do brain training, that it doesn't impact on global cognition, usually measured in the study on using the mini mental state exam. And it doesn't impact on function, so ADLs, only a small number of studies, but we're not showing evidence yet. So in terms of brain training, it's hard to then make a recommendation that, that in general, people with dementia should be doing brain training. Though, because there's not that many studies, and the studies seem to show, I haven't shown you here, that if you do brain training for memory, you improve your memory. If you do brain training for executive function or for attention, you improve your attention. So if you have a specific cognitive problem that you want to improve, it might actually make sense to train that bit of cognition. And you would need to train it quite often. And I guess the closer the training is to the problem that you're having in daily life, the more likely it is to generalize and help you in daily function. So a different type of cognitive training, I guess, or cognitive, is called cognitive stimulation therapy, which was developed by Amy Spector, Bob Woods, and Martin Orrell in the UK. And here are the training manuals, which give you an idea, I guess, of the types of cognitive activity that happen there. So there's music, there's cups of tea, there's discussion, there's, I guess, reminiscence, discussion of the news, all kinds of, I guess, games and fun things in the group, which happen in cognitive stimulation therapy. This is what the groups look like. They've also tried running cognitive stimulation therapy for someone individually, and it was not as successful as running as a group. So I guess in my head, I haven't run any of these groups myself, but I've watched some videos. Cognitive stimulation therapy is a group discussion where you socialize and you do cognitively stimulating activities as part of that group. And there's pretty good evidence that cognitive stimulation therapy improves cognition overall. So here's a relatively old review now of this, and the evidence has been such that the NICE guidelines, the European guidelines, certainly recommend cognitive stimulation therapy as a treatment for dementia. And well, in Australia, it hasn't taken off. We don't see that many groups. Certainly, it's run very across quite a lot of the UK. And when my recent trip to New Zealand, certainly New Zealanders are starting to roll it out. So that's another way, I guess, of getting the brain to be thinking and active and practicing and exercising. And I think the social component is really important in that. So cognitive rehabilitation is work from Linda Clare. And in cognitive rehab, it applies the principle of rehabilitation to address different types of need at different stages of dementia. So here are some goals that people who are receiving cognitive rehab would set. So learn to use email to keep in contact with friends, or develop strategies to feel confident enough to go out alone, to be able to cook a meal without getting distracted, or for people with more moderate stages of dementia, being able to dress yourself still, managing difficulties with swallowing, or still being able to participate in an enjoyable activity. So cognitive rehabilitation is based on setting goals for people and then working with them to achieve those goals. And while the name says it's cognitive rehabilitation, kind of talking to Linda Clare, it's much more about functional or daily living or daily life or well-being rehabilitation, rather than focusing on improving someone's condition. And there's for those of you who are interested, this is the kind of the first nice manual that I've seen about cognitive rehabilitation. Now, how about the evidence for this? Well, Linda Clare's early work compared cognitive rehabilitation to an active control group and found that the cognitive rehabilitation group improved on goal performance and satisfaction, actually improved in their memory, and in a small subset, improved on MRI data. This more recent data from a similar group is basically showing that the groups that got cognitive rehabilitation improve over time compared to the controls who didn't. We're still waiting for, I guess, the big trial of cognitive rehabilitation to come out, and Linda Clare's working hard on that. And it'd be kind of exciting to see more studies kind of looking at individualized treatment to improving, to rehabilitating people with dementia. So moving on, I guess, to communication or speech and language pathology. This is an area that has received relatively little research so far, even though it kind of makes sense that people with dementia often have difficulties in communication, and supporting them to communicate better would help. Most of the research has focused on people with frontotemporal dementias, like primary progressive dementia. And this study basically shows that you can help people with primary progressive aphasia find words that they are forgetting if you help them train. But it's quite an intensive exercise. But there's quite a few studies in this area, and we're hoping that speech pathologists or specialists in communication will be working more in this area. Now, this is these images terrible. I really dislike it, but it does show in it how gait and mobility are affected in dementia, and there's a whole lot of really complex things that are happening, which explain why people, which affect why people with dementia have poor gait and balance and why they fall. So it's to do with physical conditions shown here on the left. It's to do with how they move and walk here. It's about how they react, and it's about how the executive function and attention stop them or help them, or in reacting to when they're likely to fall. We're doing a small bit of work with, I've got a PhD student doing a tiny bit of work on improving gait and mobility in people with dementia, but there's still kind of heaps of work to be done. And Manuel has a lab in Europe where he's doing some really interesting work in this area. Oh, I was going to say, typically people with dementia have been excluded from falls intervention studies. And there's one study here in Australia now, led by Jackie Close, which we haven't seen the results of, looking at preventing falls in people with dementia. So again, it's an area I think that needs much more work. So activities of daily living and instrumental activities of daily living. So this is daily function, looking after ourselves and getting out and about and doing the things that we do in life. There's quite a few studies now, not lots, but quite a few, but most from Laura Glitton's group, showing that occupational therapy improves function. Well, I mean, it's not surprising that that's what occupational therapists are good at doing, but they've been shown that it works for people with dementia as opposed to it doesn't work. And on top of that, that occupational therapies will improve quality of life for people with dementia. So here's our study, and I just want to acknowledge my team, including the peer supporters who work with us on this study, and Kate Swaffer. So we started doing this study based on Kate's work, I guess, on her experiences of prescribed engagement. I know you've probably all heard her say that she was told to give up work, give up study, and get her end of life affairs in order and get acquainted with aged care. And that this results in people with dementia giving up hope, losing self-esteem, becoming isolated, taking on a sick role, and withdrawing from potentially beneficial activities. So the dementia lifestyle coach, I guess, is a direct challenge to this, and it supports someone with dementia to live well post-diagnosis. This is what the program looks like. We have a coach, counselor, a psychologist who provides 14 hours of coaching and counseling based on setting goals to live well. So a bit cognitive rehab-y, but with less of an emphasis on functional well-being and more of emphasis on on mental health well-being. Helping the person adjust to the diagnosis, manage feelings, and we're also coaching them, encouraging them to stay physically, mentally, and socially active, because that's what the evidence suggests is good for dementia. We also have a peer supporter who lives with dementia, who talks to the person about once a month for an hour a month. We can have those conversations how they like. The coach or counselors aren't there, so it's a peer-to-peer conversation, and it's structured so the person can provide emotional support, informational support, and practical tips. And I guess most importantly, appraisal support, so how the person sees themselves. So I guess I'll digress slightly to tell a story then from this study, in that we have a lovely man who we're working with, and he doesn't use the word dementia in relation to himself, even though he knows that he's here for a dementia study and all our forms say dementia and stuff. And our clin psych who's been working with him has been really struggling, I guess, with the acceptance bit. So he kind of will still say that he doesn't understand why he's coming and he's got no problems. The peer supporter who's been working with him, she said that in their second conversation, he finally used the word dementia in relation to himself, and he kind of tested it. He just tested saying that he had dementia, and he only did it once. But I think that was a remarkable breakthrough for us in just being able to, for him to have a safe place where it's okay to have dementia, and we all, I guess, as a team, support him and value him, and it doesn't matter about that label, and that's just a label, it's not him. So we have a lot of conversations with our participants about how they're not the label's not them, and how the label, I often get my people to hold it up, like we write down all the problems that they're having with their memory or whatever on a bit of paper, and I say, look, these are all getting in the way of your life, so you need to put them down. We need to figure out how to put them down so that you can keep on with playing golf or whatever's really important to you. So I think what we've learnt, I guess, so far, have I got slides? Yeah, so what we've learnt so far in our 9, I think we have the 10th one coming on Friday, in our 9 participants, is that people come to us at all stages of their acceptance of their diagnosis, so knowing where they are. We have one person who had done all this amazing work with his family already before he came, and cried and talked about what it meant and stuff. And we have some people who I guess are still in denial, And some people where their family issues really are such that they really need to sort out family before they can even talk about the diagnosis. When we finish the study, we'll think about what the program should be and how we involve family a lot more. We've been ad hocly including family in meetings as people want them. And it seems to me that including family in some way is really important in a program like this for most people. Not every person, for most people, they've wanted to bring their family along. Some of them from the start and some of them maybe once. So we'll have the results from this pilot, I guess just showing that we can recruit people and that we can recruit peer supporters and we can run these sessions, which I think we can say we can do now. And we'll be looking forward to refining the program and doing a bigger study. So some other work that I've been involved in is led by Yoon-hee John, and it's called I-HARP, the Interdisciplinary Home-Based Reablement Program, funded by the NHMRC. And this is a pragmatic study where we're trying to look at I-HARP, the impact on I-HARP on self-care function, and look at how we can implement I-HARP within health and aged care services. So I-HARP is an implementation study. Like we're not delivering the program ourselves. We're teaching occupational therapists and nurses and other allied health professionals within aged care services and health services to deliver this program. So this is a 4-month program. The intervention itself is 4 months, which consists of occupational therapy, nursing, and other allied health, typically a psychologist, but sometimes nutrition. And the participant also gets $1,000 of home modification or assistive technology. So we're making the home safer and we're putting in devices which might help them live better. So technology being part of rehab. It also involves care support, 3 sessions. And I guess contrary to what sometimes happens, we want to make sure that the OTs, the nurses, and the other allied health kind of talk to each other and work together in the program. I will show you a little video. I think I've been talking for quite a while now. Of the I-HARP study.
Mum's always been really a most supportive and loving, generous, proud Polish lady. You know, I just remember the smells in Mum's kitchen of plum cakes by the trays.
Tricky recipes, and you can't look in a book, you have to be in your head.
I knew something wasn't quite right, saying, "Hey Mum, do you remember that recipe?" Mum said no. The diagnosis was vascular dementia and Alzheimer's. I was Mum's full-time carer. I thought I was okay, but looking back, I really wasn't. I was really burnt out.
I-HARP standing for Interdisciplinary Home-Based Reablement Program for people living with dementia at home. I-HARP is quite unique. It's a 4-month bundle program. It's delivered by an occupational therapist, registered nurse, and other allied health professionals, plus home modifications or assistive devices provided.
When I saw that, I thought, wow, occupational therapist, registered nurse, oh, like this sounds great. And there goes Mum with the bell, that's the bell.
Valentina is an absolutely gorgeous young woman. When I first visited Valentina, she was a little bit apprehensive. She did have a lot of concern about her strength.
To me, like I said, I am not going to walk anymore.
We built our rapport quite quickly.
OTs and nurses set goals with the client, goals that they actually wish to achieve.
Back onto your chair, so you're sitting down.
But when it comes to decision making, it's the client who makes the decisions.
You put a lot of effort into that, didn't you?
Some of the changes that we saw quite quickly was that sense of confidence, even with tweaking a few things around the home environment. We saw that her walking ability had improved significantly, going outside, which gave her a really nice sense of purpose.
Mum thought, yeah, I can do this, and felt so good, and could actually physically see her thinking about things. It really increased her confidence. With the registered nurse, talking about incontinence, bowel issues, going through all the medication.
She was willing to relearn things that she had forgotten. It's about re-enabling them to manage their just day-to-day life. When you improve their function, their mood improves as well. They have a reason to get out of bed in the morning.
It's not like you just have a one-off visit, it was the follow-up.
In our program I-HARP, we work very closely with the person with dementia, but we also work closely with their family carers.
That was great that I could then use some of the tools and that I could go ahead and do some activities with Mum. Mum bought this house she's in about 23 years ago, and she really loves her home, and that's why we're doing our very best to keep her in her much-loved home.
So we conducted I-HARP pilot study. All 9 participants in the intervention group managed to stay home after 12 months.
I think I-HARP has a unique position in health. You're not receiving a referral just to address one specific need. It looks at the whole person.
Plum cake. Plum cake. It's very popular especially I think in Australia, because here is the climate, everything grows. Even I'm growing still bigger.
It's just lovely to see. She's almost 90 years of age and she is still working very, very hard to make the most of her life.
It's such a relief that I can go to bed at night and I know that Mum's safe, she's in her own home and she's happy.
Thank you very much from my big heart. How much is there left? I don't know. For all this great job you did. Merci beaucoup. Dziękuję po polsku.
So I guess I-HARP is quite a shift from what normally happens in occupational therapy in Australia at the moment. So 12 home visits is lots more than people normally get. They normally only get 1 or 2 for home safety at the moment. So negotiating how that gets funded has been really interesting. Similar to I-HARP is another OT intervention that we're implementing called COPE, which is led by Lindy Clemson and funded by the NHMRC Community Partnership Decline Centre. It's got and it's got lots of project partners. Again, we're working with project partners, including private occupational therapists, aged care services, and health services, and we're trying to implement more occupational therapy and nursing into these services. This study's a little bit further along, so I can tell you a bit more about what we've learned in this. So it's based on Laura Gitlin's work, which showed that in an RCT where the researchers delivered the intervention, that after 4 months, people on the study had improved in their function and activities of daily living and more engaged. So, so we're interested, I guess, in how we adapt this American intervention and implement it in Australia in our health system and our aged care system. Can we actually get people to not just get the clinicians to learn to do the program, but find ways of delivering the program, which is 10 sessions, I think, based on the funding models that we already have. And this is a big challenge, and it will be a big challenge in any country, finding 10 sessions of occupational therapy, funding for 10 sessions of occupational therapy. So we've done most of the study now, and we're writing up. We trained 38 occupational therapists, and of those, 27 have delivered most of the program, and we've certified 15 of those therapists. So it was hard to even get the therapists to go from those who were keen to do it and were trained to getting them to implement the full program. Of the therapists who have implemented the program so far, remember I told you it was 10 sessions of occupational therapy that we were trying to get them to implement. Quite a few therapists actually managed 10 consultations, and kind of most consultations were kind of in the 5 to 10 range. So it was actually pretty good, better than what we were hoping. We were thinking some of them might manage less than 5. So I guess, remember, we're not funding the visits, we just funded the training. So they had to find ways of funding the visits as part of a home care package or the healthcare system package. So the organisation and the therapists had to value this program enough to find ways within their funding structures to deliver the program. So I think this is quite pleasing for us actually to see quite a large number of home visits happening as part of the program. We were less good at the nurse following up with the session. There's one or two nursing sessions, and that was done less well than the occupational therapy sessions. And this is I'm just going to move this, you can see. And most of them did follow the program in that they had to address 3 goals. You can see problem 1 is the first goal, problem 2 is the second goal, problem 3 is the third goal, and most of them did that pretty well, at least addressing 1 or 2 goals. What have I done? Yeah, so what we've learned from COPE, I guess, is that with training, we can implement rehab, essentially, which is what COPE is, into aged care and health services in Australia. But it's quite difficult that there was a lot of work with the services to figure out how they took a research program and adapted it into a program they could deliver with their funding in their context. And that, well, and we don't have results of whether the program helped people yet. We will have small bits of data, but it's mostly an implementation study. But that once we do a trial that shows that intervention works, there's still a lot of work in figuring out how to then deliver it at scale to people in the community as well. So I want to talk a bit about terminology, because I think in our head, rehabilitation looks like this, that you have someone who can't walk and they walk, and then you've rehabilitated them, and you win a star as a clinician. In our head anyway, it's hospital-based or outpatient clinics, and it usually involves allied health with physical functional goals and daily functional goals kind of emphasised. In Australia, and I think in most countries, we also have transitional care. So this is for people who are in hospital, and people are helped to go home. They get a short amount of care. In Australia, it's 6 weeks, might be slightly more or less in other countries. And again, it's to optimise functioning. And then there's this term we see around restorative care or reablement, which are led by allied health professionals that are meant to help people make a functional gain. And it's time limited and usually target daily functioning. And then this much softer term here in Australia anyway, which is again time limited, may or may not involve allied health, and is trying to help someone do better. And then there's this wellness approach, which we hear, which is the softest or least high, which is just encouraging independence in daily living. So this appears to be in Australia anyway, and in the literature generally, this kind of continuum of terminology for rehabilitation, with like people getting lots of gains, and then we do less and less, and people get lots of less gains. And as I've been thinking about it, I'm like, it's all rehabilitation, and it seems like we use the terms reablement and wellness because it seems more acceptable that we could do these things for people with dementia. Well, it's all rehab, and I think it's that rehab clinicians, and I'll show you a bit of work that Modification's been doing with rehab clinicians, have an expectation of what rehab is. And we just need to learn what we should expect when we rehabilitate people with dementia, and we give them allied health services and other supports to live well. So on the soft end then of rehabilitation is our reablement study, where we're trying to implement more reablement and person-centered care in residential aged care. So we know that person-centered care is the best type of care and improves quality of life. It also helps with behavior, and but we also know that most people say they do person-centered care, but they don't. So this was a program that we wrote to try and implement more reablement and person-centered care in residential aged care. So the intervention involves training staff and changing procedures within the facility. I'll tell you a bit more about some of those changes. And what we were hoping to do is engage residents better and engage staff better, so that ultimately residents would have better quality of life and function. So the first change, I pinched the whole idea from Daniela Greenwood from Arcare, was dedicated rostering. So in some nursing homes, a resident might meet a whole lot of different people each week who shower them and look after them. And so we tried to roster staff to small areas of the facility so that residents only had a small number of people who were working with them. This doesn't cost any more money. It does cause slight headache for the rostering and staffing of the facility. But it means that residents only see a small number of the same faces each week, and also the staff, I guess, have a set number of residents who they're supporting. On top of that, we allocated a focus carer to each resident. So that was someone who was meant to build a relationship with that person, be their advocate, get to know them well, find out more information about them, and take the lead in focusing on their well-being. In facilities where this worked well, the focus carers started to come to care planning meetings, and they really were like monitoring and getting to know and looking after that person really well and finding out all kinds of things about them. What we managed to do is that for all the residents, we managed to allocate a focus carer in our pilot study. They completed an all about me, so a life history of the person. So I don't know if you go to facilities, life histories are often completed by someone in the nursing team or the lifestyle team, and no one ever sees them, or this is completed by someone in their rostering, dedicated rostering team on the floor. And we got people to come to training, which is a challenge in itself. So here are the outcomes. This is a small pilot study with 76 residents, and we improved quality of life overall on the ASCOT and in the domains of dignity, occupational engagement, and safety. We improved mood on the Cornell and function on the disability assessment for dementia. I want to tell you, I guess, a story because I think the stories make a difference in this. And this is Lucia, who we have permission to tell these stories and show these pictures. So Lucia was a migrant from Italy, and when we started working with the facility, the staff were really scared of her. She would come and knock on the door in the, one of those glass goldfish bowl nursing stations. She would knock on the door and they would hide in there, and she wanted to talk to them all the time and be with them. And they were so scared of her, and she would squeeze them and she would pinch them, and they didn't know how to look after her. They didn't know how to, make her comfortable or happy. And then they found out about her history and her role, and they realized about her role of being a provider and looking after people, and really needed to be busy and help people. And they found ways of involving her all the time in all the activities that they did, because that's what she'd done all her life. So she is pushing the food, the coffee trolley. They found ways of involving her, I guess, in their jobs, in helping them make the beds and sweep the floor, so that she had meaning and purpose in life. and she really got to know the staff really got to know her, and she still pinches and punches them. Oh, she doesn't punch them, but she still pinches them, but in a way, I guess, that they're not scared of her anymore, and they understand now how to support her in living well. Here's Doris, who talks about horses all the time now, and she remembers the time when she was in her 20s and she met her husband, and she was in a riding club. And what Doris wanted for her goal, because we get residents to set goals, because I'm all about setting goals now, so we get residents to set goals with their focus resident. Doris wanted to go on a horse, and the facility thought that they couldn't do that, so they got Doris a horse for the afternoon, and she got to pat it, and it was in her house, and that was really, I guess, really meaningful and wonderful for her to have this experience. And it's a small thing, but it's a big thing at the same time. Seeing Doris and understanding where she is and meeting this kind of small goal for her, it's beautiful. I guess the Whidden Group rolled out Lifeful to all their facilities, and they won a big prize about it. And I guess in terms of research, the small paper that we wrote about it, but in terms of impact to me, it's been a really important piece of work, and that we showed that it can be done. Doesn't cost much money, and other facilities are looking at implementing either our program or something similar. And in some ways, they don't have to use mine. As long as they take this approach and do it, I would be happy. So we called it Reablement because I think if we called it Rehabilitation, no one would be prepared to do it. But I think these days it's much more about social rehabilitation that the work that we're trying to do here, and a little bit of functional rehabilitation. We talk about exercise and stuff, but it's about people having a life and being supported to have that life. That's important. So I'm really excited, I guess, to share this news that Kate Labour and I are going to be editing a book on dementia and rehabilitation. In my head, I was like, I really need to write a big literature review in this area. And then I was like, well, I don't know enough about speech or gait or other areas to do this. So this, in my mind, is a big literature review that we've talked to a whole bunch of people to helping us write, which will look at the current evidence. We're making sure that we have a clinician involved in each chapter who can write some clinical recommendations, even if we have little research evidence, and to identify research gaps. So this will be a guide, I guess, for future research in the area. And I think also a resource that we can say to clinicians, look, there is some evidence and some recommendations from clinicians, going forward and doing this now. So this will come out in 2020, and we have a book contract with Elsevier. DAI have a chapter penciled in, so I'm looking forward to contributions from Kate or whoever gets kind of harangued into writing that chapter of the book. So to close, I guess, this is some work from Monica Cations, who's been looking at attitudes towards rehab and dementia. And some of the attitudes that, this isn't published, so I'm just kind of got permission to show some of these findings, is that people say, well, this doesn't apply to me. Rehab and dementia doesn't apply to me. That's someone else. Or rehab will only work for certain people with dementia. For example, they need to have insight, or they need to be able to follow instructions, or, it won't work for everybody. No one's going to fund this, or it's not cost effective, or I could spend the same money and have more benefit for someone else. And yeah, the extra resources aren't worth it. They're going to deteriorate in the long run. So I think that these slides and Monica's work suggest that really, in terms of trying to implement rehab, that the attitudinal barriers are massive. And we can, as researchers, generate lots of evidence, but clinicians and policymakers aren't going to fund it or put it into practice unless we start doing a lot of work in the changing the attitudes and belief space as well. So there are lots of research gaps. We don't know much at all about rehabilitation in terms of communication, social participation, balance and gait. And an area that I did talk about is perception as well, but perceptual changes in dementia and how we support people to manage those perceptual changes. I don't see anyone doing work in that area. Certainly there's different types of dementia, different levels of severity of symptoms, and these might need different approaches. We need to show cost benefit because that's a barrier. And cost benefit for quality of life or disability years lived, lost, we need to show that is cost effective, because that's the currency of funders. We need much more discussion about how we involve people with dementia and their care partners in the interventions, how we use technology, how we could implement these in developing countries. I mean, some developing countries, there's no OTs at all, so it would look really quite different as a model, I think, to implement an OT intervention in a developing country, a low middle income country. And I think there's lots and lots of barriers: ageism, stigma, denial, apathy, and the attitudes and skills of healthcare professionals as well. So I'm just going to do a big plug, because one, I'm really interested in stigma, and I realized that I've got some of you people with dementia here, and I really want to hear some of your ideas about stigma, because to me it's a big barrier in rehab, but in also people getting early diagnosis and other work. And I'd be really interested to speak to some people in a web working group to help me with my grant. Basically, I must help. So if you're interested in being part of a web working group, which would help me co-design some research on stigma. Stigma is experienced by people with dementia, stigma in the general public, and stigma in health professionals. Just drop me a line. You can find me in the internet, and I'd really like to talk to people from around the world who want to help me think of questions that are important to you in the area of stigma. So to close, I read a lot of Terry Pratchett because I was kind of a nerdy kid, and he wrote this quote: I remember on that day of rage thinking that if I'd been diagnosed with cancer of any kind, at least there would have been open in front of me a trodden path. There would have been specialist examinations. There would have been short summer machinery in place. I was not in the mood for a response that said, more or less, go away and come back in 6 years. And I see that what our job is as researchers, everyone, I guess, is to figure out what that trodden path should be. And we need to kind of make the steps for that path. And in rehab and dementia, there's still no path, but we can start to figure out what the steps should be. Thank you.